Okay, well, welcome to week 7. This week we're going to talk about drugs that affect the pulmonary system, but you probably figured that out when you saw the cover slide. I love this graphic because asthma is one of those conditions that spans almost all specialties. Pretty much anybody that's listening to this that's in an APRN program will encounter asthma at some point, whether you're going to be a pediatric nurse practitioner or adult or acute or primary care or whatever. Like asthma is one of those things that just spans the entire population. It's also one of those conditions where there's a real dichotomy between, like, we have awesome knowledge base of asthma, we have excellent drugs for asthma, we have excellent evidence to tell us how to assess, screen, assess, diagnose, what's the word I want? Categorize, and then treat and then follow up asthma. And yet we still have relatively very poor control of asthma in the general population. There are still too many exacerbations. There are way too many asthma deaths annually, deaths that could be totally prevented if the asthma were better taken care of. So asthma is a really important topic of conversation in an APRN program. Of course, there are many other pulmonary conditions as well. And we'll look at the drugs that affect all of them, really. But as with most things, I guess, there are a collection of medications. There are a few classes of medications, and we use them to treat almost all pulmonary disorders. But the thing about asthma, to bring this part of the conversation full circle, what you see in front of you here is a mucus plug that was extracted from a patient who died of an asthma exacerbation. And when you look at this thing, I mean, the first thing that should jump out at you is the size. This thing is appreciably over 5 centimeters in length. And the other thing is, look at the detail, like the asthma that becomes inspissated in the bronchi during the worst. I mean, obviously this is the worst case scenario because this was extracted during autopsy. But when patients have an asthma exacerbation, not only do they develop bronchoconstriction and wheeze, but they also have hyperemia, increased mucus production, tachypnea, which dries out the mucus. You wind up with a really dry, hard collection of mucus. And if we don't control the exacerbation, that mucus plug literally plugs up the airways, and you wind up with a dead patient. And what you can see here that I think is so remarkable, aside from the size of the plug, is look at the level of the detail. This thing was so hard that it was lifted out of a patient and still maintains all the detail. I mean, it looks like cement. Usually mucus you think of as sort of, I don't know, runny or like egg-like, and you would expect that when you pick it up, it would just become a big blob. But this thing was so dried out and so hard that it's like a perfect mold of the inner, of the inside of the bronchial spaces. And that just gives you an idea of what asthma can become if it is not properly managed. So on that happy note, let's see what's up next. So let's see. Yes, always, this is always the philosophy. If you want to understand how drugs impact a condition, we have to look at what's going on in that condition. And so with respect to the pulmonary tree, there really aren't a whole lot of different classes of medications. Remember, when we talked about, like, say, cardiac stuff, there's lots of different classes of medications that we use for different cardiac and vascular conditions. In the pulmonary world, there's really just a handful that we use for our pulmonary problems, and depending on the disorder, we may use them differently. In some conditions, we'll use one drug first. In other conditions, we'll use another one first, but it is a pretty small collection of drugs. So first, let's think about what goes wrong, and then we'll look at the classes of drugs that we use to treat them. So these are some common pulmonary conditions, and I mean, maybe some of them are a little less common, but COPD and asthma are the two biggies. COPD obviously is not typically a pediatric problem. Asthma is the one that is a standout in terms of almost every population will encounter it, but COPD in the older adult, the middle-aged and older adult, is very common, and both the acute and primary care providers will encounter this. And when you get into your clinical courses, you will find that there is a very pure genetic form of COPD that is seen in young people. Pneumonia is another thing that spans the life cycle, right from the neonate all the way up to the frailest elder geriatric patient. Pneumonia is an infectious disease, so we attend to the infection with anti-infectives, And then we have to help the airways be able to accommodate and survive the acute infectious and healing process. So again, some of these same drugs that we use for all the other pulmonary things, we will use in pneumonia too. Sarcoidosis, a little less common, but just another, I mean, there are several other pulmonary conditions. There's interstitial pulmonary disease. There is pulmonary fibrosis. I mean, there are other things that can go wrong with the lungs, obviously, but we really do use this same handful of drugs over and over to manage the pulmonary aspect of any condition. If you work in a critical care scenario like this slide says, there are some other things that you will expect to see in an exacerbated state, like ARDS, pulmonary embolus, and acute failure, and yet still we use this same handful of collection of drugs to get the patient through the acute episode. Sometimes there are other specialized things that we will use as well, and really pneumonia is the best example of that in the last slide. In this slide, it's a pulmonary embolus. I mean, we will virtually always anticoagulate the patient, and in some cases, actually, a thrombolytics, or even in rarer cases, an embolectomy, depending on what's going on, but we still have to support the airway as the patient survives this event. So with that foundation in mind, for all of these conditions in general, pharmacotherapy centers around these three things. Number one, reducing inflammation. Number two, stimulating bronchodilation. And number three, blocking bronchoconstriction. And these are all different things, so you really want to have that mental mindset. These are very different. Reducing inflammation is a standout. I mean, there are lots of conditions where we attenuate the inflammatory response and try to suppress inflammation. That's true. It's very important in the pulmonary world. But stimulating bronchodilation and blocking bronchoconstriction are two very different things. And we have a collection of drugs that will stimulate bronchodilation and other drugs that will block bronchoconstriction. And very often they are used together because these are two distinctly different features of the airway, both of which, number 2 and 3, we will try to manage with pharmacotherapy to maximize the patient's ventilation and gas exchange and get them through whatever acute event is going on, or even control whatever chronic event is going on. So probably the most important takeaway message from this slide is that promoting bronchodilation and blocking bronchoconstriction are two very different things. So in asthma, inflammation is the primary problem. It's the primary target of care. And our gold standard, like our gold star approach to chronic asthma management, you'll see will be to suppress inflammation. And again, I always, I have to watch myself and cross the line, because it's not our role here for me to go into disease management. My primary role is that you understand how drugs works, so that when you get to a disease management course, you'll understand why you're putting certain drugs in place for certain conditions. But sometimes it's a hard line to stay behind. So, and asthma is an example of that. Asthma is about inflammation, really. I mean, we will certainly acutely try to reverse acute bronchospastic exacerbations, but the gold standard, the primary goal of asthma, chronic asthma management, is to suppress inflammation. This is the one pulmonary condition where suppression of inflammation is the #1 target of chronic pharmacotherapy. With just about every other pulmonary condition you may encounter, it's going to be, even if it's not the primary goal of therapy, it is a very important secondary goal. So suppressing inflammation is important. Producing or increasing bronchodilation allows patients to ventilate. And so this is another obviously a critical function. Sometimes producing, or I don't know if I love the word producing, promoting bronchodilation is the #1 most important thing. In other conditions, it's a #2 thing. But, my point being, always you will see these used to some extent or another in treating symptomatic pulmonary conditions. And then finally, blocking bronchoconstriction is a separate physiologic mechanism. It is also important with respect to promoting ventilation. And remember, when we talk about ventilation, we talk about getting air in and out of the lungs. When we talk about respiration, we're talking about gas exchange at the level of the alveoli. So ventilation is getting air in, respiration is about gas exchange. And blocking bronchoconstriction is a very important physiologic mechanism with respect to promoting ventilation. So those are the three things primarily that we will target with drug therapy. But the one thing we can't forget about is cough. Can't forget about cough. Cough is like one of the very top reasons for office visits in the primary care setting, certainly in the pediatric world. Cough is, if not the most common, it is certainly one of the top 3 reasons why parents bring their children for an outpatient office visit. And even for adults, cough is a very common complaint. In fact, it's so common, there's a whole science of cough. And in fact, I think I've linked, I think there's a link in your external readings. The American College of Chest Physicians has a whole guideline on the assessment and management of cough and all of the different things that could cause it, and that identifying cause is the most important thing most important feature of figuring out how to treat it. So when somebody comes in with a cough, it's not just that we throw a cough medication at them. We want to think about what it is demonstrating. What is the cough indicating? And then does it need treatment or not? Remember, cough is a major protective mechanism. This is one of the most important ways we have of keeping irritants out of the airway. So sometimes cough is a necessary evil. It is the thing that saves your life. Certainly, if a patient is aspirating, we don't want to inhibit cough. We want them to be able to cough so that they can get the irritant out. In terms of like conscious sedation or sedating people that don't have an airway, an ET tube or a trach in place, one of the big concerns is not suppressing the cough reflex, because we want people to be able to cough. However, sometimes it is exaggerated, sometimes it is unnecessary, so sometimes it's appropriate to treat it and sometimes it's not, and we will talk about drugs that we use to manage cough. So I think that's that. Oh yeah, another slide here about the business of cough. Do keep in mind that when patients are coughing, they do always want something to stop it. And sometimes that is appropriate, but many times it's not. If cough is an exaggerated response or an inappropriate response, then yes, we want to give people stuff to attenuate the cough. However, especially in the pediatric population, and again, I guess I'm crossing a line here, but those of you that are PEDS programs and FNP programs, you'll talk more about PEDS when you get to your clinical management stuff. But like I said, coughing is a real common complaint for parents to bring their children in, and the safety of cough suppressants or cough medications in especially a younger pediatric patient really has not been well established. And if any of you are doing any sort of PEDS rotation, whether PEDS is your major or you're an FNP, when you do your PEDS rotations, one of the very first things you'll be told is that we are very careful about cough medicines in little kids, because FDA data on safety is almost non-existent. And there are lots of pediatric providers who just flat out will not medicate cough at all. A friend of mine who is a pediatrician, his philosophy is no cough medicines, period. And he tells parents no child ever died from coughing, but children have died from using cough medication and having it, either used inappropriately or they aspirated or whatever. So his philosophy is no, we'll not medicate it. The end. And it always surprises me that patients keep coming to him because cough is such an important pediatric complaint. However, I suppose he is well enough respected in his patient population that they do keep coming back even though they don't get cough medicine. So just as a side note, keeping in mind, sometimes it's appropriate to medicate it, sometimes it's not. Patients will always want it medicated. Let's face it, we all know cough is annoying, but remember that our role as the professional is that we are professionals. We understand the issues and we treat appropriately. So don't let people push you into prescribing a cough medication if you don't think it's an appropriate thing to do. That's really the moral of that slide. Okay. So the review of relevant physiology is contained in these next few slides, and it may seem very basic and pedantic, but again, I think one of the biggest flaws is in glossing over the basic stuff too much, and then people don't have a good handle on the basics of why we use drugs. So if you'll indulge me, let's take a few minutes to look at the relevant physiology. And not pathophysiology of disease, but just normally what goes on with respect to ventilation and respiration, or ventilation and perfusion. So gas enters the pulmonary tree by way of the nose and less often the mouth. We're supposed to breathe through the nose, right? The reason we're supposed to breathe through the nose is that the nose serves some important purposes like filtration and humidification. We all have nose hairs. Nose hairs aren't necessarily very attractive. You know, lots of people clip off their nose hairs, which, I mean, if it's hanging out of your nose, I totally agree. Please do clip it and save us all the visual. But nasal hairs in your nose are really important. They are the first line of defense. Remember, the entire conducting airway, beginning with the nose and down to the bronchi, is to get clean, filtered, body temperature air down to the alveoli to participate in gas exchange. Clean, filtered, and temperature. That's what the conducting airway is for. And nasal hairs are the first line of defense in trapping large pieces of debris. We all know that there's all kinds of crap floating around in the air. You even just on a bright sunny day, go outside, and when you catch looking at the air through the rays of the sun from the right angle, you can see everything floating around in it. If it's change of season, you see all the pollen. I mean, sometimes when you go outside and breathe in the change of season, it's like taking a bong hit. There's so much like visible debris in the air. Nasal hairs will trap that. And even if it's not visible, there are dust particles. You know, there are certainly things. There's dust mites. If you have animals or you're around animals or any place where stuff is kicked up, there's stuff in the air that has no business being in your alveoli, and nasal hairs, they exist to trap that. So nasal hairs, while they are not necessarily the most attractive piece of the human anatomy, they really are important in trapping the larger pieces. And a lot gets through it. And then the things that get through it are too small, and then they will go down to the defense mechanism. But nasal hairs, extremely important as a first line of defense. Then, for those smaller particles that do manage to survive the nose hair, the next line of defense are cough receptors. So cough receptors are located primarily in the trachea. Cough really isn't a lower lung thing. Cough is really an upper airway phenomenon. Remember that the trachea, its anatomy is such that it can't constrict. It can't like close up to keep bad stuff out. The size of the trachea is fixed. Oh, you can see your slide is telling you. Look, I'm going on and on here and not even reading your slide. But the slide says it. It says, remember the trachea, composed of smooth muscle and cartilaginous rings, is incapable of constriction. Even though it's made of smooth muscle, the cartilaginous rings in the trachea keep it from constricting probably just as well, because like it's already narrow enough. If you consider, you know, like the pressure of air out in the atmosphere, which is very low, and then air's got to get into the trachea, and the trachea is so much more narrow, you already need to generate a driving pressure to get air into the trachea. If you even can constrict the trachea even more, you're going to need huge amounts of pressure to get air in, and that's not going to happen. So anyways, the trachea can't constrict. It's a good thing. So how does the trachea protect the lower airway from those smaller particles that get through the nose hair, or air that comes through the mouth, which presumably you don't have any air in? You know, if you breathe through the mouth, the first line of defense is going to be the trachea. So the trachea's line of defense are cough receptors. When particles, even microscopic particles that you can't see, when they get as far as the trachea, the cough reflex is stimulated. So that's your next line of defense. Let's see, what does the last bullet point say? In general, the only indication to directly suppress cough reflex or neural centers that trigger cough is when the patient is intolerant of cough from an oxygenation perspective. And that is true, and it's an excellent point. If the patient is coughing so much that they're becoming hypoxemic, then yes, you have to medicate the cough, because the consequences of hypoxemia can be catastrophic. The example that comes to mind here is COPD. Some people with more advanced forms of COPD, when they start coughing, they will become hugely hypoxemic, and then it is very appropriate to help suppress the cough reflex. Other than that, there's really not the only, the indication for suppressing the cough reflex is patient comfort. And not to, I'm not dismissing the importance of patient comfort. It is important sometimes. Some people, like if they cough all night and they can't sleep, they can't perform at work the next day. If I were having a cough right now, I would have to do something about it because I need to be talking to you without interruption for the next, for this hour and a half or 2 hours. I can't be coughing every minute when I do it. So there are definitely reasons where, quote, comfort or convenience, or however you want to phrase it, do enter into your decision making. But from a very purist perspective, the reason you're coughing is to clear something that your airway recognizes shouldn't be there. And the only reason to medicate it, like any other reason to medicate, is when the benefits of medication outweigh the risks. So clearly, if a patient is at risk of becoming hypoxemic, that is an indication to suppress the cough. The rest of it, well, it's a judgment call. I mean, I have patients who, like they're drivers, truck drivers, delivery drivers, stuff like that. And if they don't sleep the night before, they could really be a danger to themselves and others on the road. So I do tend to be a little bit more liberal with cough medicine for patients like that. In pediatrics, I'm not quite as hard rule as absolutely no cough medicine for any reason whatever, but I am a lot more strict about it just because most kids can survive cough without, other than truly it's just being uncomfortable. There's no other real consequence there. So anyway, again, I digress. Right now we're talking about normal physiology, and the normal physiology is that the conducting airway system exists to take air from the atmosphere and get it down to the alveoli, clean, free of debris, body temperature, and capable of engaging in gas exchange. The first line of defense in cleaning the air are nose hairs. The second line of defense for those smaller particles that get past the nose hair or the air that is inspired in the mouth, the next line of defense is the cough receptor in the trachea, because that's the only way it can defend itself because it can't constrict. Let's see, gas continues to warm and humidify in the airways, and that's true. The further it gets down the airway, the closer to body temperature it gets, and large debris gets filtered out. But there may still be some microscopic debris that finds its way all the way into the airways. Examples are things like cigarette smoke, right? If you inhale cigarette smoke or anything, of that size, the same relative size, it's going to get past the trachea. Your next ventilation airways or conducting airways are the bronchi and bronchioles, and their mechanisms of control include goblet cells and cilia, as well as bronchoconstriction. So the bronchi are capable of constricting. They have smooth muscle, but they don't have those cartilaginous rings that the trachea has that maintains their size. So goblet cells and cilia are next. And goblet cells and cilia work together to trap microscopic debris and get it out of the airway. So the goblet cells produce mucus, and mucus traps the stuff that, now I'm going to cough. Okay, I paused for a minute so you didn't have to hear it, but it's like whenever I start talking about cough, I start coughing. I guess that's just the psychosomatic thing. Anywho, mucus cells, they trap it. So mucus cells are constantly producing mucus. You and I are producing mucus as we sit and, listen or talk. I guess I'm talking, you're listening, but we're both producing mucus all the time. It's microscopic amounts. It's not huge. You would never normally know it's there, but what it's doing is trapping those very smallest molecules that got past the trachea. It's trapping them in mucus, and then cilia are beating them toward the upper airway. The upper airway back toward the throat, so that you will then swallow the mucus and you eliminate this debris through the gastrointestinal tract. Again, when you're not having an infection of some sort, when you're not having bad allergies, just like on the normal day-to-day, you never know this is happening, but it's happening to all of us all the time because it's a normal physiologic defense mechanism. We produce mucus, we trap debris, we push it by way of cilia up toward the throat. It makes its way into the mouth or throat or whatever anatomy you want to call it until we swallow it and it comes out the other end. And that is yet another defense mechanism. And I just said this, so I probably don't have to say it again, but the slide is here. So I will just remind you that we're not talking about huge amounts of mucus here. We're not talking about something that you would ever even realize under normal circumstances, but it is happening. So these are three important ways to protect the air that gets down into the alveoli from having any sort of crud in it. because in alveoli, we need to have pure body temperature air to participate in gas exchange. And if it moves down this airway normally, we presume, reasonable temperatures on the outside and reasonable temperatures on the inside, respiration will be just fine. Did you ever notice that in like extreme cold environments or extremes of hot environments, you feel like you get out of breath more quickly, or it's just a little bit harder to get a good deep inspiration? It's not that ventilation is a problem there, but in extremes of temperature, it's a little bit more difficult for the body to normalize the temperature of the air by the time it gets to the alveoli, so gas exchange may not be as efficient. And I mean, I'm talking like really cold, like sub-zero cold, or extremes of heat. You just always feel a little bit like respiration, or at least I always feel like it's just a little bit less efficient. Like if you suddenly go out into the freezing cold, and I don't mean freezing in 32, I mean really, really cold. It's like, when you breathe in, you just have to like keep at it. Anyway, it's because of the extremes of temperature. The ventilation system exists to clean the air and to warm it to body temperature so that it can optimally participate in gas exchange. If debris, and we're talking seriously microscopic here, but if debris manages to get past the nasal hair, past the cough receptors, and past the mucus, and this is possible if it's less than 1 micron, so there's all sorts of truly microscopic things that get down there. But if crud manages to get all the way down past all of these defense mechanisms, then it gets to the alveoli. The alveoli is not capable of constriction. It's not capable of mucus production. This is why we don't want anything to get down there. We want to filter it out all in advance. But if you smoke every day, for instance, every day stuff will get down to the level of the alveoli. So the alveoli's defense mechanism isn't about mucus or constriction. It is about the good old-fashioned inflammatory response. So if you get crud all the way down into your alveoli, you will have a macrophage response. Macrophages will mobilize to the site, and whenever you have macrophage, you're going to have like loss of gas exchange spaces. You're going to have distortion of alveoli. You're going to have loss of alveolar attachments. And if it goes on long enough, the alveoli become unusable. And the alveoli are your gas exchange spaces. So, everybody once in a blue moon may have an exposure to something, or you may, get pneumonia, get a viral infection, and for a transient period, there will be things that get down to your alveoli. Your alveoli will incite a macrophage response to neutralize it, and for a little while, you'll be a little less comfortable, maybe a little less efficient with your gas exchange, and then you will recover. The body will debride those macrophages, and that's the end of that. But for people that persistently, every single day, expose their alveoli to these microscopic particles on a daily basis, they're having macrophage migration to try to eliminate it. And over time, this will compromise the ability of the alveoli to do its thing. This is one of the important mechanisms behind smoking and how it causes damage to the alveoli. But it's not just smoking. If people who, another thing that comes immediately to mind are people who work around, like industrial solvents, industrial chemicals, and don't wear their masks the way they're supposed to. People that work in mines. In one of my clinical lives a few years ago, I worked out in a place where I had a lot of miners. And now, OSHA is involved, and everybody's supposed to be wearing the appropriate face masks, and there's appropriate ventilation. But stunner of stunners, not everybody follows the rules, and sometimes bad things happen. And these are things that can, on a daily basis, expose you to this microscopic damage in the alveoli, and that's how you wind up with long-term obstructive airway diseases later on. And then finally, I think the last thing, that's what it says, the last piece of normal pulmonary physiology that we have to review as a foundation for drug study is the influence of sympathetic and the parasympathetic. So, collectively they are the autonomic nervous system. I feel like we've had this conversation somehow in another, I'm sure we have. The autonomics have an influence on almost every part of the body. But with respect to the lung, we have distinct sympathetic and parasympathetic influences, and they're actually really important. So Under normal circumstances, bronchi are surrounded by epinephrine. Epinephrine is constantly in circulation. Our lungs are swimming in it, and it's a good thing because epinephrine binds to beta-adrenergic 2, beta-2 receptors, and produces bronchodilation. This is the sympathetic nervous system influence in the lung. It comes right back down to that fear, flight, or fight response, right? If you have to fight a stressor or flee a stressor or fight, and be fearful of a stressor, fear, flight, fight. If you have to have some acute reaction to an acutely stressful event, you need to have maximum respiration, right? Maximum ventilation and respiration. And so the epinephrine that mobilizes during an acute stress response will bind to beta-2 receptors and cause acute bronchodilation. This maximizes air delivery to the gas exchange spaces. You will have zero resistance to inward flow at the level of the alveoli, and life is beautiful. You can maximally breathe. That's the normal state of affairs. You and I, as we are sitting here, our lungs are under primarily sympathetic tone, and we're breathing without any problem, hopefully. Parasympathetics, on the other hand, is the protective mechanism. So our lungs are well innervated with parasympathetic receptors in the form of muscarinic receptors. Muscarinic receptors are to the parasympathetic system what beta-2 receptors are to the sympathetic system, and they're on standby. They're on red alert. When something finds its way into the airway that doesn't belong there, and it manages to bypass the nose hair, the cough receptors, told you I always cough when I'm talking about coughing, and it gets down into the bronchioles, in addition to goblet cells and cilia, another mechanism of protection is bronchoconstriction. So if your lungs become stimulated by I shouldn't say your lungs, if your conducting airways become stimulated by the presence of something that doesn't belong there, one of the things that will happen is acetylcholine release, and acetylcholine is the neurotransmitter that will bind to muscarinic receptors and cause acute bronchoconstriction. So obviously, under normal circumstances, you and I don't want to be bronchoconstricted, right? At rest, without a threat, there is no meaningful parasympathetic influence going on in terms of the pulmonary tree. But when necessary, if you aspirate something, if you're drinking water or drinking whatever and you aspirate it, or if there's a lot of smoke in the room or heavy particles like perfume or like whatever the case may be, and it finds its way into your conducting airways, the lungs will recognize that it's there. It will release acetylcholine, which will bind to muscarinic receptors and cause bronchoconstriction. The ultimate goal to keep that stuff from getting down to the alveoli. The entire conducting airway exists to get air in that's clean and warm and free of debris. So again, these parasympathetic responses like bronchoconstriction should only happen when there is something there that the body wants to keep out. Now, in some conditions, you may have a heightened parasympathetic response, like there is a belief with COPD, perhaps because of the constant, perpetual introduction of debris into the conducting airways, the patients have a heightened parasympathetic response. So that's a disease state. But in the healthy state, your bronchi are controlled primarily by sympathetic influences in the form of epinephrine binding to beta-2 receptors. So when we're treating common pulmonary disorders, sometimes there are other therapies we use to treat the particular etiology of the disorder, and sometimes not. Sometimes we are targeting primarily these mechanisms, but either way, at some point, we will always be trying to maximize recovery and maximize ventilation by either inhibiting inflammation, promoting bronchodilation, blocking bronchoconstriction, controlling cough, or any collection of all of these things. Because no matter what else is going on, sometimes a real priority of care is just making sure the patient can ventilate and respirate while we try to treat the underlying problem. So, like I said, there are a handful of medications, and this handful of medications are going to help us do all of these things, whether we have to target another underlying etiology or not. So, the first class of drugs here are the beta-adrenergic agonists. These really are a mainstay of managing pulmonary disorders, whether it's the only thing we need to use or an adjunct therapy. You know, those of you that work in the hospital setting, if you work with a lot of like ventilator patients or, you know, people coming in with whatever respiratory problem, you'll know that the overwhelming majority of them are also on albuterol treatments or beta-adrenergic agonist treatments, either at regular intervals or at least PRN. Almost everybody on a vent will have treatments. Albuterol is the word I'm looking for here. We'll have albuterol treatments because whatever else is going on, we want to make sure that that airway is maximally dilated to contribute to maximal introduction of flow. So beta-adrenergic agonists, the only class of medication that produces immediate bronchodilation. This is the rescue drug for all forms of pulmonary distress, whether it's something as minor as you know, an asthma attack. I mean, I hate to say minor, but in the scheme of things, even if it's a minor asthma attack or even like an acute hypersensitivity response with anaphylaxis, what do we give people with anaphylaxis? We inject epinephrine, and epinephrine is the pure beta-adrenergic agonist. So whether it's an asthma attack where you give an albuterol inhaler, or any condition where the patient is on, you know, chronic respiratory care, and we give them, whether it's albuterol nebulizers or we attach it to the vent or whatever, all the way up to acute bronchoconstriction, cannot breathe, have to inject with epinephrine to keep them alive. Beta-adrenergic agonists are the rescue therapy of the pulmonary world. Beta-adrenergic agonists do come in both short-acting and long-acting forms. The short-acting forms are your rescue therapy. The long-acting forms obviously are not. If somebody needs acute bronchodilation, we're not going to give them something that will act in a couple hours. We want to give them something that acts right now, right? But this is the rescue drug. So, and like I just said, it is short-acting drugs that are the rescue version. So albuterol is the prototype inhaled short-acting version. There are numerous brands under which under which they are marketed these days. Like Ventolin, Proventil, ProAir. Those are just the ones that come immediately to mind, but there's a ton of them out there. They're just different, and some may have little different twists, like they might say this one onset is 1 minute where another one's onset is 2 minutes. I don't even pay attention to what those distinctions are. I really see them as more marketing ploys than anything else. But albuterol is the short-acting form. And of course, injectable epinephrine is also a short-acting form. Although obviously we don't use injectable epinephrine unless we can't use inhaled albuterol. If you want somebody to have a short-acting beta agonist on board immediately, you should use an inhaled form unless the patient just flat out can't inhale, like somebody in anaphylaxis, and that's what your injectable form would be like. I mean, we just always want to use the least invasive way to do a thing. This is why we don't have all of our asthmatics like running around with EpiPens injecting themselves every time they have an asthma attack. We have them holding an albuterol inhaler so that when they have an attack, they can inhale it. And with respect to mechanism of action, these do what you would expect a sympathetic nervous system stimulant to do. They bind beta receptors and cause immediate bronchodilation. So long-acting forms are, just like your slide says, a long-acting or sustained release version of albuterol. But these are long-acting. They don't act right away. They are not rescue therapy. And this is truly a critical part of patient education. We don't want people reaching for the long-acting beta agonist when they're having an acute bronchospastic event. There are several forms of these available now on the market. In fact, in your external links, I did actually just add a one sheet list of the various drugs used for pulmonary disorders, like the brand names. Salmeterol is marketed as Ceravent. It's been around forever. And Formoterol is marketed as Foradil, and it has been around forever. These are pure sustained release albuterol. There's no other drug in there. There's no combination agent. When we get to this toward the end of this slide set, we will emphasize that there are lots of inhalers that are combinations, two different classes of drug in one thing, and then there's other forms that are just one drug. Right now, we are talking about long-acting bronchodilators, sustained release bronchodilators. The only med in the inhaler is a long-acting bronchodilator. This is not a rescue therapy for anything. I think I told you in the beginning of this discussion that it's been really well identified that we have in the world of asthma management, it's a real dichotomy that we have excellent knowledge, excellent evidence, excellent drugs, excellent education tools, and not excellent management of asthma. We have too many exacerbations and hospitalizations for exacerbations. And one of the big reasons for it is theorized to be that we are not educating patients properly about the differences among their inhalers. So the reason there was a black box warning, because there were increased asthma deaths with these long-acting forms, is that patients didn't understand the difference between, say, salmeterol, which is long-acting, and albuterol, which is short-acting. And when they would have an asthma attack, they would reach for the long-acting drug and they would die. So, hopefully this will make a little bit more sense when we get to the end of this slide set. But a really critically important safety point to remember is that there are short-acting forms of beta agonist and long-acting forms. Short-acting forms are rescue therapy. Long-acting forms are not. Long-acting forms are used for certain conditions where on a consistent daily basis, we want the patient's airway to achieve a sustained level of bronchodilation that we support with pharmacotherapy. It's not appropriate to be using short-acting bronchodilators on a daily basis. And this is another thing that you will see patients doing all the time. You'll see people writing prescriptions for this, and it is flat out not appropriate. Short-acting bronchodilators like albuterol, they reverse a bronchospastic event that is already happening. We don't want that. We don't want people just medicating after something happens. We want to control their pulmonary condition so that the bronchospastic event does not happen. That's one of the things that a long-acting bronchodilator can do for us. So when you see people that are using albuterol every day, this is not appropriate. That's a clue for us that whatever their pulmonary problem is, it is not well managed. We want to get it under good control. And then if we're doing a good job managing their pulmonary condition, they won't need to use albuterol twice a day. When you get into your clinical management courses and you start talking about asthma, or for that matter, any pulmonary condition, you will see that a real standard we watch for is that if patients are having to use their albuterol more than twice a week, that means their underlying disease is not well controlled, and we need to be more aggressive about treating the underlying problem. So the takeaway message here, long-acting forms are not rescue. And you want to make sure every patient you ever treat with one knows it, because there had been so many deaths that for years we had a black box warning. That black box warning, by the way, was just removed in 2018. So apparently we've finally gotten better at teaching people about this, so now we want to stay that way. Beta adrenergic agonists, as we have said, they work by mimicking epinephrine. And so they will cause other adverse effects or other systemic effects outside of the world of the lung. And that's what this next slide is about. So you know what happens when you give somebody epinephrine. Epinephrine is a stress hormone. In vivo, right, endogenously, when you're exposed to a stressor, your adrenal medulla will release epinephrine to prepare you for fear, flight, fight. When we give people albuterol or a long-acting form of albuterol, we are giving synthetic epinephrine. So yes, we will dilate bronchi. There will be bronchodilation. So breathing rate will also increase. They will become tachypnic. Intestinal muscles relax. Relax meaning they're not peristalsing. They're not moving contents forward. I mean, the last thing you need when you're fighting a stressor is to have to stop and have a bowel movement. And your body knows it. So if you're having a stress response, your intestinal muscles will relax. Pupils will dilate because you have to be able to see. We want your vision, your peripheral vision, to be optimal. Blood pressure increases to maintain distribution of blood to the essential organs like the brain and the heart and the lungs. Blood sugar levels increase because glucose is the most rapidly acting form of fuel to produce ATP. So again, these all gear you up to fight a stressor or flee from a stressor, as the case may be. Heart rate increases, blood flow to your skeletal muscles increase so that you can move more readily. All these things happen when you give epinephrine. So these all happen when you give synthetic epinephrine as well. And when you put people on albuterol treatments, they will very commonly describe a sense of agitation or sometimes a sense of palpitations. They feel like their heart is breathing too fast. Their pupils will dilate. This is just, it's part of the downside. So giving people albuterol in a short or long-acting form will sometimes produce these other systemic responses. In the short haul, for short-acting albuterol for patients that just need rescue therapy, it's a no-brainer. The need to breathe is the most important thing. So if somebody's having an asthma attack or they're having an anaphylactic reaction and we inject them with epinephrine, whatever, they will get tachycardic and tachypnic, and they may get a headache from the blood pressure, and they will get hyperglycemic and all that stuff, but they'll be breathing, so the trade-off is a fair one. Now, when you're talking about long-acting beta agonists like Ceravent or Foradil, that we use on a daily basis for chronic disease management, sometimes people will experience these adverse effects, and they won't take these meds for that reason. So it's something to keep in mind. But the takeaway message in the short term is, if you give somebody epinephrine, you can reasonably expect all of the consequences of epinephrine to occur. Bronchodilation is the one we want, but all of these other ones can occur, and we didn't want them. Then we have to consider parasympathetics and how parasympathetics impact the state of bronchi and breathing. So remember the parasympathetic and sympathetic nervous system. These are the two branches of the autonomic nervous system. And for some reason, I'm almost certain that recently we had this conversation about sympathetic being the fear, flight, fight, and the parasympathetic being the part of the autonomic nervous system that just maintains the day-to-day stuff, the boring stuff. Fear, flight, fight is exciting, right? You're going to fight a stressor, so your heart rate increases, your bronchi dilate, your pupils dilate, you're all ready to go and have a big fight or have a great run or something like that. Parasympathetic is not nearly as exciting. Parasympathetic is just the day-to-day sludge or drudgery that keeps you going. I mean, you got to have it. If you didn't have it, you'll notice some problems, but the parasympathetic nervous system maintains vegetative function. So, for instance, it helps balance that pupil dilation by promoting pupillary constriction. You don't need to see everything all the time. If you did, you would have actually probably, sensory overload and be non-productive. So parasympathetic stimulation will constrict the pupils. It's a protective mechanism. If a very bright light is shined in your eyes, you will constrict your pupils to protect you from sensory overload. Parasympathetic stimulation stimulates the salivary glands so that you can begin to digest. The parasympathetic, aka cholinergic, we call it the cholinergic system because it's driven largely by the neurotransmitter acetylcholine. So parasympathetic / cholinergic, they're the same thing. It will stimulate salivary production so you can eat, you can begin salivary digestion, because the sympathetic nervous system is real important in maintaining vegetative functions like nutrition. So not only will cholinergic stimulation stimulate salivary glands, it will also stimulate the lacrimal apparatus so that your eyes will water so they can stay protected. It will stimulate peristaltic contraction in your stomach and your intestines so that you can mix a food bolus, move it forward, and have digestion. It will stimulate the colon so that you can excrete. It will stimulate the bladder so that you can empty urine. Actually, somebody coined the mnemonic SLUD. We call these the SLUD effects: salivation, lacrimation, urination, and defecation. And I'm telling you, I'm having such deja vu, like I have had this conversation with you before. So if I did, just move past it. But if I didn't, you distinguish the parasympathetic nervous system basically by considering it as the SLUD effects. Parasympathetic stimulation will help you salivate, lacrimate, which is your eye watering, urinate, and defecate, keep your gut moving. The parasympathetic nervous system is also the part of the nervous system that makes you vomit when the stomach needs to empty. The parasympathetic nervous system will slow down your heart rate. Like when you're just sleeping or eating or just laying around doing nothing, you don't need to be all tachycardic. You do need something to slow your heart rate down a little bit. That would be cholinergic or parasympathetic stimulation. The other thing, that fast I lost it. Oh, the bronchi. We're talking about the lungs here. Parasympathetic stimulation will cause bronchoconstriction, which is a protective mechanism if your lung perceives something there that doesn't belong. So these are two very separate things, sympathetic and parasympathetic. Sympathetic stimulation causes bronchodilation. Parasympathetic stimulation causes bronchoconstriction. And that's the context in which we are talking about drug therapy. Sometimes we do have conditions where parasympathetic bronchial stimulation is happening inappropriately. Sometimes, just to try to maintain optimal ventilation and optimal air movement, we want to block the ability of the lung to constrict, or I keep saying lung and I shouldn't. We want to block the ability of the bronchi to constrict so that we can maintain it in the most dilated, like greatest diameter state that we can. Now, cholinergic stimulation also is one of the things that produces mucus secretion. So if you give an anticholinergic, one of the things that you will do is block the ability to make mucus, so you will produce a dry lung that cannot constrict. Cholinergic stimulation as a protective mechanism causes mucus secretion and bronchoconstriction. Sometimes to manage an airway or to sometimes just support ventilation until we treat an underlying problem, we give anticholinergics that will block mucus secretion and block bronchoconstriction. So again, this slide just reiterates what I just said. Sometimes I just get excited and speak ahead of myself here, but you will see that in asthma and COPD, we very often will do both things. We will give drugs that promote bronchodilation, we will give sympathetic stimulants, and at the same time, we will block cholinergic mediated bronchoconstriction. So we'll give anticholinergic medications along with sympathetic stimulants, because together they result in an airway that is as dilated as we can make it with drug therapy. So ipratropium bromide, which is marketed as Atrovent, this was the first pulmonary cholinergic that was on the market. This is an inhaled medication, right? It acts topically. So this is a good thing, because you know that if you give a drug, like if you give a systemic drug, like something orally that's an anticholinergic, you will get lots of other anticholinergic effects in the body. And anticholinergic effects in the body are often unpleasant. So if you block cholinergic stimulation everywhere else, you're going to block the ability to slow down the heart rate. You're going to block the ability for the intestines to contract. You block the ability of the bladder to contract. You block the ability to salivate. So what you wind up with is dry mouth, urinary retention, constipation, tachycardia. So we don't want to do that if we can help it. So having Atrovent, which is an inhaled anticholinergic, it's not well absorbed from the pulmonary surface. It really is a topical agent and works just locally to the lungs. And it was the first anticholinergic we had, and it is short acting. It's going to work very quickly. Then we had Spiriva, which is tiotropium bromide, and that was the first long-acting anticholinergic. And we typically call these muscarinic antagonists, right? They block muscarinic receptors. So we can use the term inhaled anticholinergic or inhaled muscarinic antagonist. They mean the same thing. And both of these drugs, whether it's a short-acting or a long-acting one, will block parasympathetic, which is the vagal system. It will block parasympathetically mediated bronchoconstriction. And there are a ton of these drugs available on the market. Well, maybe not a ton, but there's easily 3 or 4 other long-acting anticholinergics. So again, that thing that I told you I linked in your I put a link in your external readings there. That's just a list that shows you some of the common drugs. I would like you to go over that because there's several combination agents there. And they're different combinations, and they use different things, and we use them for different reasons. So I'd really like you to understand what they are. And by the time we get to the end of this slide set, all of that will make much more sense. Again, these are inhaled agents. They don't have any systemic impact, so they're not going to cause dry mouth or tachycardia or constipation or anything like that. Primary safety and patient issues are about the implications of suppressed protective mechanism. Remember, the cholinergic system of bronchoconstriction exists to protect the airway from letting debris get past all of the other protective mechanisms, right? So of course, if you give an inhaled anticholinergic and you block the ability of bronchi to constrict, you do run the risk of allowing microscopic debris to get down to the alveoli. That is a risk. It's just like everything else, a risk-benefit analysis. Usually by the time we're giving people these drugs, we just really need to keep that airway at its maximum diameter, and so we are willing to assume the risk. We do always really encourage good pulmonary hygiene for people that are having to use these medications. So by way of asthma as an example, because it is such an excellent example, what are the cholinergic responses in asthma? In asthma, the cholinergic response, and it's a heightened one, right? Asthmatics have an exaggerated or heightened response to stimuli. So like if you or I are exposed to a really smoky room or, really heavy perfume or something like that, we'll cough a little bit. Our trachea realizes something is there that shouldn't be. But often patients with asthma will have a heightened protective response. They will have increased mucus production. They will have increased bronchoconstriction. They may go into bronchospasm, and that's their lung trying to protect themselves in overdrive. This is different from a beta-adrenergic agonist. We give beta-adrenergic agonist in asthma to directly promote optimal bronchodilation. So again, good patient education really is the thing that's going to maximize outcomes here. The National Institutes of Health has convened a study on why we don't have good asthma control in the population. And one of the biggest contributors to the poor asthma control was identified that providers are just not properly educating people the differences of these inhalers and when to use them. And part of that is because the providers don't fully appreciate the difference in the inhaler. So my job is to educate you so that you will know and then educate them. And then together we can all hugely reduce the impact of asthma in the general population. So think about it. In the case of asthma, as I'm sure you remember from pathophysiology, the underlying problem is abnormal inflammation. The airways are abnormally inflamed. Because they're abnormally inflamed, they are very susceptible to being triggered by any minor irritant. So like you or I, like I said, we get exposed to an irritant, we might cough a little bit or whatever, no big thing. But the patient with a chronic inflammatory problem in the airway, when they're exposed to an irritant, they get profound mucus production, bronchoconstriction, and that's what produces this horrific mucus plug you see in front of you. And so we will often medicate both the sympathetic system, trying to dilate them, block the parasympathetic system so they don't get this big ugly mucus plug, and get best patient outcomes. We'll come back to more of that later, though. And I alluded to this before, but I guess just by way of reminder before we leave this particular topic of conversation, there are lots of drugs that have anticholinergic effects. They're not respiratory drugs. They're not designed to have any impact on the airway, but because they have anticholinergic properties, they can interfere with the lung's ability to protect itself. And here are some examples. Tricyclic antidepressants, which I believe we have talked about, they are powerful anticholinergics. So you have to be cognizant of that. Not that it's like any overt phenomenon, but you might see that somebody who has that's on tricyclic antidepressants, just be aware of their vulnerability perhaps to pulmonary infection because their protective mechanisms are dampened just a little bit by the anticholinergic properties here. First generation antihistamines are another drug that have significant anticholinergic properties. Opiates are right up there. Antidiarrheals and anti-bladder spasmodics, those drugs are by design anticholinergics. I mean, diarrhea happens because you have heightened peristaltic activity, which is driven by acetylcholine. We give antidiarrheals to block that. And the same thing with bladder antispasmodics, like people that take meds for urinary incontinence. We give them drugs that are anticholinergics. We're trying to block that excessive urinary spasm, but at the same time, there's the potential for anticholinergic effects in the rest of the body. So that's the story there. And we close off this discussion of autonomic influences by going back to this thing one more time. I can't impress upon you enough how important it is to recognize that the lung, its diameter is controlled by both sympathetic and parasympathetic influences. Sympathetic influences are epinephrine binding to beta-2 receptors, which maintain normal steady state bronchodilation. That's the normal state of affairs. When your lung is introduced to something that is potentially toxic or an irritant, you will have burst cholinergic activity. Acetylcholine will be released, bind to muscarinic receptors, and cause mucus production and bronchoconstriction to trap the thing, get it moved forward, and at the same time bronchoconstrict so that this debris can't move any further down. And we have drug therapy that impacts both of them. Now we're going to talk about drugs that suppress inflammation. All right, so now let's take a look at some of the other core drugs that we use to suppress pulmonary symptoms. And the next one up is the group of drugs that suppress inflammation. So the inflammatory response, I mean, you know, it can be triggered body-wide. It is a protective mechanism. Very often when we have an inflammatory response, it's the thing that keeps us alive or keeps us safe or whatever. But sometimes it is also very inappropriate and exaggerated and disproportionate to the stimulus. And so that's what we always have to weigh. When we suppress inflammation, we have to weigh the benefit of suppressing the inflammatory response against the risks of suppressing it. So like your slide says, like in pneumonia, patients will have an inflammatory response. It's one of the ways that the lung gets rid of the infecting organism and allows itself to ventilate as best as possible. Other times, like I said, like in the case of asthma, the underlying problem is inappropriate chronic inflammation. And so then we most definitely want to suppress it. So here is one of many schematics of the inflammatory response. It's actually not the best one I've ever seen, but it tells the story well enough. When it comes to the things that we're talking about now, like pulmonary conditions, our primary interest is in the consequences of mast cell activation. So you see your mast cell here on the upper left of the screen. I just put a circle around it. When you are exposed to an antigen, which is the foreign substance, whether it's a virus or a bacteria, or just a dust particle or pollen or something like that, an antigen is something that doesn't belong there, and the body will immediately mobilize mechanisms to try to get rid of it. And you will see B cell activation, IgE cell activation, and it's the IgEs that stimulate the mast cell to do the things that it does. Mast cells also go on to activate pro-inflammatory mediators. You will see T cell activation and all the interleukins. But look to the left of the screen here, directly from the mast cell activation, you will see the production of histamines, leukotrienes, chemokines. These all directly cause bronchospasm. Also, mast cell activation will liberate neutrophil migration, and neutrophils, you know, are those white blood cells whose job it is to neutralize bacterial infection. You can also see that the mast cell stimulates eosinophils, and I'm drawing an arrow just because it's a little further down. Oh, God bless it. My drawer is not so good. Eosinophils are those particular white cells that respond to allergens and irritants. So activating mast cells can trigger lots of things to happen to protect you. Neutrophils will arrive to the scene in case it's a bacteria. Eosinophils will arise to the scene in case it's an allergene. Histamines and leukotrienes will trigger bronchospasm to protect the airway from anything getting further down. And this is what happens when the airway is insulted. Like I said, sometimes it is the appropriate thing to happen. It needs to happen to protect the lower airways. Sometimes it is excited inappropriately. But when you consider these processes, then you can consider what the drugs do that we give people to try to neutralize them. So the first group of drugs are the antihistamines. I mean, the name pretty much tells you what they do. One of the consequences I've learned of recording a narrated PowerPoint is that I can't back up the slide. I can't reverse it to emphasize a point. If we were maybe in a live classroom, I might back up the slide to point out to you exactly where histamines are an issue and why giving antihistamines makes a difference. So I'll have to ask you to back it up when you're listening. But if you go back to slide 37, you'll see that histamines are one of the things produced by the mast cells that stimulates bronchoconstriction or bronchospasm. Again, in the normal circumstance, this is a healthy response. If you inhale, say, like a mouthful of pollen or something, and it gets past your cough receptors, you need bronchospasm to protect your lower airways. So sometimes histamines serve a very important function, but when they go out of whack, when they're out of control or inappropriately stimulated, that's when we give antihistamines to block the action of the histamine with respect to bronchoconstriction. You might hear my son's dog in the background getting himself comfortable. Just ignore any doggy noises you hear. So in the world of antihistamines, we have sedating and non-sedating antihistamines. This is not a complete list. It's just meant to be representative. The sedating antihistamines are H1 receptor antagonists. The thing that makes them sedating is that they cross the blood-brain barrier and they can block histamine action in the brain, so they can produce that drowsiness and sedative kind of property. And it can be rather significant. Almost all of the over-the-counter sleeping medicines like Tylenol PM, Excedrin PM, like all that kind of stuff, the PM part, the sedating part, is diphenhydramine, which is the generic name for Benadryl. Meclizine, you might know as Antivert. This is an antihistamine that we give to people with vertigo. This is also an antihistamine, not a sedating antihistamine. Hydroxyzine, you might recognize as Vistaril. So there's lots of sedating antihistamines out there, and diphenhydramine is available in over-the-counter formulations. The thing about them is they cross the blood-brain barrier. Non-sedating antihistamines don't, so theoretically they cannot cause sedation. Cetirizine you would know as Zyrtec, and of these three, fexofenadine and desloratadine are Allegra and, oh gosh, I'm going to forget. There's Zyrtec, Allegra, and one other one. Let me remember this. But I guess you'd think I know this off the top of my head. Cetirizine is Zyrtec. Fexofenadine is Allegra, and desloratadine is Claritin. So, and there's probably others out there. They're kind of the big three. So they don't cross the blood-brain barrier. Those are H2 receptor antagonists. Now, Zyrtec, there are studies that demonstrate that there is some slower reaction time. So sometimes people will tell you, yes, Zyrtec does make me a little tired, but it's not as profound as the other antihistamines. It is important to recognize that it's not that one group are any better at antihistamine properties than the other. The difference between the two is the sleepiness. Sometimes you want to capitalize on that. Like if somebody are having allergies, you know, runny nose, rhinitis, maybe a little itch or something, and it seems to get worse at bedtime, which many times it does, because sometimes the things that stimulate the allergen response, like if they have a cat that sleeps on the bed all day, or just, you know, if the bedroom door is closed and there's no air movement in the room, and just normal dust mites and dander accumulate on the pillow in bed and stuff. Anyways, for a lot of reasons, people sometimes their allergies will be worse at night. And so it actually is a good thing to give them a sedating antihistamine. It improves their symptoms and it can help them sleep. On the other hand, if people need an antihistamine during the workday or during some time where sedation is an issue, then obviously you'll use a non-sedating form. But neither of them are better at suppressing symptoms than the other. They both are pretty much the same. Let's see, blocking histamine receptors decreases the available stimulus for bronchoconstriction, and we saw that in that graphic. In other words, this is a symptom control drug. This is rescue therapy. It works after the mast cell has been stimulated, like after you're already exposed to the thing that you've been exposed to. You do want patient education here, because in an ideal world, people that have symptoms, we prefer not to medicate them after the symptoms happen. We prefer to educate them and sometimes medicate them with different kinds of medications to keep symptoms from occurring. In the case of what we're talking about now, say with allergies, because that's often what we use antihistamines for, in the case of allergies, we don't want to give them a pill after they start having allergy symptoms. Ideally, we teach them how to keep those symptoms from happening in the first place, like allergen avoidance is a big deal. Education about allergen avoidance, like if you get allergies really bad at nighttime, if there's a carpet in the bedroom, remove it if you can. If there are cloth curtains on the windows, don't go in the bedroom after it's been closed up all day, open the window and then go to bed. The curtains will they'll move around and all the stuff that's on them will come off. Like things like no carpet, maybe wooden or plastic slats or blinds or covers, washing the sheets frequently in very hot water. These are all just some examples of things where the point being, we always want to control a condition rather than rescue it. So controller therapy, and sometimes there are drugs that are controller therapy, and sometimes there are non-pharmacologic actions that are controller therapy. That's always what we want to maximize. And then the rescue therapy is if symptoms occur anyway. Sometimes it's just a breakthrough thing, like a couple times a week or certain times a year, and then it's very appropriate. But if a patient's having to take an antihistamine like every single day, then we really want to take a closer look at what mechanisms we can do to control the condition so that their mast cells are not stimulated in the first place. Again, first generation antihistamines cross the blood-brain barrier, so it will produce sedation. So either you want to make sure that doesn't happen or capitalize on that. Also, keep in mind that cough centers are in the brain. You know, the receptors are in the trachea, but the reaction, the motor response after stimulation, the motor response to produce a cough actually originates in the brain, and those cough centers are activated by histamine. So antihistamines will actually suppress the cough reflex, but of course the antihistamines have to be able to cross the blood-brain barrier, so only first-generation antihistamines will do it. And I think you'll see when we talk about cough in a little bit that first-generation antihistamines are among our first choices for suppressing cough, say in like an acute viral upper respiratory infection. And yep, again, second generations don't cross the blood-brain barrier. So where they are used in the mast cell response are primarily things like itch, rash, things like that. These just don't have any meaningful action in the brain. Now, of course, the other side of that is that because they cross the brain, they do have some anticholinergic properties. And you know, in the lung, we said that anticholinergics will actually suppress that bronchospastic response. And, you know, that's one of the things that we want them to do. But also remember that anticholinergic properties can cause lots of side effects in the rest of the body, like tachycardia, sedation, constipation, urinary retention. Those are the biggies. So when you give those first generation antihistamines, there may be some unintended consequences. You know, in the elderly, for instance, when you give them antihistamines, I mean, we know that the elderly are at risk for constipation anyway. So this could conceivably make it worse. The elderly are at risk of tachycardia anyway. This could conceivably make it worse. And because the elderly are at higher risk for falls, a drug that can be a little bit sedative producing could also be a risk factor. So I'm not saying don't use it, just, you know, the reason we're here is to be aware of all this stuff and choose our drugs accordingly. It's funny, you know, when I was first a nurse practitioner and first had the authority to prescribe, and of course I didn't have any kind of course like this, because back then nobody really taught us much of anything except how to, I don't know. Well, never mind, I won't go there. But we didn't have a separate pharmacology course. And so when I first had authority to prescribe, you know, I didn't know what I was doing and I was like scared to death. But I always felt reasonably comfortable prescribing those things, like in the hospital, writing orders in a chart for things that are generally available over the counter, because I would figure, like, how bad could it be? And I found out the hard way that it can be bad. In sick people, these over-the-counter drugs can actually cause some significant consequences, like, for instance, antihistamines can contribute to urinary retention. For you or me or the average garden variety person, you don't think so much about it, but think about, say, an older male patient with benign prostate hypertrophy who already is at risk for retention and then takes an antihistamine, which actually decreases bladder's ability to contract. And the next thing you know, this older gentleman with BPH has urinary stasis and develops a UTI and becomes septic. Take it from one who knows, giving antihistamines can have significant adverse effects. I think we probably had the same conversation when we were talking about nonsteroidals in the world of pain. Motrin can put people into acute renal failure. So, I mean, one of the biggest achievements of a course like this is when you're done, if you will be terrified to prescribe anything. I mean, of course, you have to be able to prescribe, but we do want to have a healthy respect for the adverse effects for what these drugs do to people. And I always tell people, the more I know about drugs, the less inclined I am to prescribe anything for anybody unless there's a damn good reason to do it. So anyway, that's the story on antihistamines. Leukotriene receptor antagonists. These drugs used to be very widely prescribed, and now you don't see them quite as much. But again, I'll harken you back to that diagram that we looked at where the antigen stimulates the beta cell and the beta cell releases IgE, which stimulates the mast cell, and then the mast cell stimulates lots of things, including the production of histamines and leukotrienes. And leukotrienes are very specific to causing bronchospasm. Histamines have lots of other actions too, but leukotrienes are pretty pretty targeted to bronchospasm. So giving a leukotriene receptor antagonist is going to block the action of leukotrienes, and that's what we're hoping to do here in the pulmonary section. So there are medications that block the synthesis of leukotrienes, and then there are those that block its action after it is produced. But again, I'll refer you back to that diagram, or actually maybe I will show it again because I forgot, but it's here. So there you go. Leukotrienes, they come from the same general place that histamines do, but histamines are just more widespread. So when the leukotriene antagonists hit the market, it was really believed like, oh, good, we'll have all of the good effects in the pulmonary tree of histamines without any of those like anticholinergic adverse effects. So these drugs just had the advantage of blocking a single stimulus for bronchoconstriction, which makes them very precise. I know you can't really tell it from the diagram that we just looked at. Like the diagram is pretty macro. It doesn't give you as much detail as it could. If you followed out histamine and leukotrienes, you would see that there could be a lot more detail in what they do. Histamines have lots of actions all over the body. Leukotrienes are much more specific for the pulmonary tree and bronchoconstriction. So the idea was we could get a similar action to an antihistamine, but without the anticholinergic properties, without all the other systemic properties. But like antihistamines, they are a symptom management drug. These are not a cure for any disease. Now, corticosteroids also suppress inflammation. They do it much earlier in the cascade. These even proximal to where we see antihistamines work and leukotrienes work. Corticosteroids block the formation of precursors to the compounds that stimulate the mast cell. So there's probably another diagram coming up here, but if you go back to that diagram that we just looked at, you see that IgE stimulates the mast cell, and then the mast cell spits out histamines and leukotrienes. Corticosteroids actually block the liberation of arachidonic acid from the cell membrane, which I know might not mean much to you now, but like think of it as working at that point where the antigen is the initial stimulus. Immediately distal to that is where corticosteroids have their action. So the upside is they are very effective for suppressing inflammation. The downside is that they have lots of other actions in the body too. Like these are not pulmonary specific. Systemic corticosteroids block inflammation, like your slide says, virtually all over the body. And I'm sure you know there are lots of steroids out there. We have inhaled forms, we have oral forms. We also have parenteral forms, right? We have prednisone, we have prednisolone, we have dexamethasone, we have Solu-Cortef, Solu-Medrol. We have all sorts of corticosteroids available. When we're talking about pulmonary symptoms, usually we use inhaled steroids. Certainly in the outpatient setting, most of the steroids we use will be inhaled because they're a topical application. They're not absorbed systemically enough to have any meaningful systemic side effects. On the other hand, sometimes when patients are in more severe crisis, we do give oral steroids, excuse me, or even in the hospital, intravenous steroids, because we just need to get it on board that much faster and that much more efficacious. So like everything else, the stronger a drug, the more likely it is to have other adverse effects. So we use inhaled steroids when we can because they tend to be very focused to the pulmonary tree. When we don't have time to play around, when we need to suppress inflammation in that airway immediately, then we will use systemic steroids. And this is a little bit better. You can see on this diagram where, like down here on the bottom right, we're looking at leukotrienes. You know, they're a consequence of that arachidonic acid liberation. But up here, the glucocorticoids, the glucocorticoids facilitate the liberation of membrane lipid to arachidonic acid. So you see, I'm drawing a little red, one of my bad arrows here. And well, that's really a bad arrow. But actually, it'll be Tui. Nobody said I was technologically competent. All right, I mean, I know that you can see this. You've got membrane phospholipid, and then you've got a down arrow to free arachidonic acid. And there are several phospholipids along the way that help facilitate that. Interestingly, what's not labeled here, is that all of these phospholipases, they are collectively referred to as cyclooxygenases. So I'm going to circle those. So phospholipases, cyclooxygenases, and even lipoxygenases, they're represented here by these phospholipase C and A2. Those are all suppressed by glucocorticoids. So if you suppress their action, you don't get stimulation of arachidonic acid. And if you don't produce arachidonic acid, you ultimately don't wind up with prostaglandins and leukotrienes. And that's how glucocorticoids will suppress inflammation. So, I mean, again, I don't expect you to remember like every term here and every step along the way. I'm not going to show you a diagram on a test and ask you to indicate where something does something. I just want you to have a sense of the different areas in which these drugs do their job and why we pick some over others sometimes. The contemporary approach now to managing pulmonary symptoms and pulmonary disease is that the glucocorticoids are the best way to go about it because they inhibit multiple mediators of inflammation. Like I said, the phospholipases, the cyclooxygenases, and the lipoxygenases. So you have suppression of multiple mediators of inflammation. And if you give them in like an inhaled form, they're not absorbed, so the systemic profile is very, very limited or non-existent. Now, when you give them orally, there is likely to be a systemic adverse effect, but we're only giving them orally or parenterally when the need for them is really urgent, and then the benefits outweigh the risk. Steroids are a stress response hormone. They are a secondary stress response hormone. I know we've had this conversation before, or I'm totally having deja vu. And I might be, because I'm teaching pathophysiology to another group, and so forgive me if I'm mixing up my groups here, but I feel like you and I in pharmacology have had this discussion about a primary stress response and a secondary stress response. But if we didn't, we can sum it up this way. The adrenal gland exists to help your body fight stressors, whether they're physiologic stressors, emotional stressors, or like whatever. Stressors need to be dealt with. And the adrenal gland has two primary areas, the adrenal medulla and the adrenal cortex. The adrenal medulla produces your primary stress hormones like epinephrine, norepinephrine, and, those two are really it. Those are the things that maintain fear, flight, fight. They get you to the fight. They're your immediate response. But then, my computer's doing a weird thing, and I'm really hoping it's still recording us. Anyway, after you get to the fight, then you have to stay there. Then you have to have a sustained response to the stressor. And that's what corticosteroids are for. Corticosteroids are, and in your body, they are in the form of glucocorticoids, mineralocorticoids. They help you sustain that stress response. So they're not an immediate response, they're a secondary one, but they're in it for the long haul. Corticosteroids are our pharmacology, the way that we mimic glucocorticoids. So they keep you responding to stressors. And they sustain your ability to fight a stressor. And so, there is potentially a physiologic downside. Because think about what your glucocorticoids do. That's what systemic corticosteroids will do when you administer them, say in the form of prednisone or Solu-Cortef or whatever. They do those things that help keep you ready to fight a stressor. They promote vasoconstriction so that you shunt blood to the brain and the heart and the lungs. Excuse me, they mobilize fuels like glucose because glucose is the fuel source that your body can metabolize most quickly. This is like insta-fuel. They promote free water excretion because when your body is fighting a stressor for the long haul, you don't need to be troubled by excess water weight, so it minimizes your water. Corticosteroids suppress inflammation because, again, when you are fighting a stressor or responding to a stressor of some sort, you can't have inflammation going on. Inflammation will hurt, it will cause bronchoconstriction, it will slow you down. And finally, corticosteroids promote osteoclastic activity. They promote the liberation of calcium from bone, which in the short haul is necessary to maintain the neural activity you will need and the skeletal muscle and myocyte contraction that you'll need. Because remember, calcium is the electrolyte of muscle contraction, and it is also the electrolyte of neuromuscular transmission. So you need calcium. So in response to a stressor, you need all these things happening. But if you like take steroids every single day, oral steroids or parenteral steroids on a regular basis, you're going to have some pathologic consequences of these things like hypertension, hyperglycemia, volume contraction. When you suppress inflammation for too long, your body can't inflame in response to a stressor, and you wind up with all sorts of things like rashes and sores and fungal infections and stuff like that. And if you promote osteoclastic activity for too long, you'll eventually get osteoporosis. So it's always a balance. If somebody can't breathe, they're in ARDS or having an acute asthma attack, of course you're going to give them systemic corticosteroids, recognizing in the short term there's going to be some of these side effects. But in the long term, that's when it can become a problem. So best bet is when we have to suppress inflammation, we try to do it with an inhaled product. That way we don't get a lot of systemic effects. And that's all I know about that. Now, drugs used to treat cough is another interesting topic of conversation. I think I mentioned before that the American College of Chest Physicians has a whole document on the assessment and management of cough because cough is such a common primary care complaint. I mean, all sorts of stuff makes us cough. Most of the time, it is a normal compensatory mechanism and it is self-limiting. Throw in a little green mucus and everybody wants antibiotics for that. Somehow, in just general conversation, green mucus became code for bacterial infection, and it's just totally not true. Green mucus can absolutely be lymphocytes, which is a viral infection. But anyway, you'll see this complaint happening all the time. So we want to think about if we treat the cough, we want to do it appropriately. First generation antihistamines are among the drugs that are considered appropriate in some circumstances. I mentioned to you before that the first generation antihistamines cross the blood-brain barrier, and that allows antihistamine activity in cough centers of the brain, and that's why it's appropriate. So for people that are having like an acute viral URI and they need transient suppression of cough, you can consider a first generation antihistamine. There are some first generation antihistamine decongestant combinations on the market. Bromfed is like the prototype one, BROMFED, that is used for the acute cough of a URI. Keeping in mind that first generation antihistamines that cross the blood-brain barrier also can produce anticholinergic properties, so use them more carefully in patients who are at risk for other consequences of anticholinergics, like patients who have BPH, patients who are chronically constipated, patients who have maybe rhythm, cardiac rhythm issues. But I mean, that is definitely one option. Another option are the inhaled anticholinergics. The American College of Chest Physicians actually recommends these for people that have post-inflammatory or post-infectious cough. Because even after you have, like if you have a viral URI and the actual organism, the actual virus is in your airway for maybe 3, 5, or 7 days, and that's the thing that starts the cough reflex, then remember that your inflammatory mediators have mobilized to the site. Lymphocytes, macrophages, eosinophils, whatever got pulled there. And those things too will produce irritation. And they persist long after the actual infecting organism has been neutralized. So there are people that will have cough for weeks, or smokers even months after they have, an acute infection has resolved. And the American College of Chest Physicians recommends anticholinergics for them. Patient education about post-infectious cough is so hugely necessary. You will have people that want a Z-Pak. Like Z-Pak is another one of those conventional associations. Oh, I have cough and green mucus, I need a Z-Pak. And you don't. When I used to see patients in primary care setting all the time, I actually, just in self-defense, made a little one-page patient education thing about post-infectious cough and what it is and what it isn't and why antibiotics are not appropriate for it. So anticholinergics, remember, they block cholinergic stimulation. Inhaled anticholinergics are topical applications. They don't have a systemic property. So it's not like if you give somebody an inhaled anticholinergic, you're not going to produce constipation and sedation and all that stuff. You're just going to suppress acetylcholine-mediated constriction and mucus production in the lung. And so these are very appropriate for post-infectious cough. Now, expectorants for years, probably for decades, were considered the drug of choice, and guaifenesin is the prototype expectorant. Expectorants don't suppress cough in any way. I mean, none of these drugs actually suppress cough, although antihistamines do suppress stimulation of cough centers in the brain, but they don't actually suppress like the cough response, the cough receptors in the trachea. Anticholinergics, they don't suppress cough at all. They just block parasympathetic mediated bronchoconstriction and mucus, which can lead to cough. And in the same vein, expectorants don't suppress a cough. All they do is thin up secretions so they're easier to move and the cough response isn't triggered. Thick secretions will make people cough. They will cough more, they'll cough longer, they'll cough harder, and expectorants just reduce the surface tension of the mucus, making it easier to come out. So you'll cough, you just won't have to cough as much is the idea. Forever, these were considered the drugs of choice, although in more recent history, there's some downsides asserted about them. One of the concerns is that in the same way that they decrease the surface tension of mucus, they can decrease the surface tension of platelets and make them less likely to activate when necessary, so ultimately can put somebody at risk for bleeding. Oh, and look, I just said it on the next slide. I got excited and said it ahead of myself. Yes, they reduce the surface tension on mucus and decrease your cough, theoretically, but they also can reduce the surface tension of platelets. So, again, for you and me, probably not a big deal. But for somebody who's got a bleeding tendency, maybe they're on Plavix or they're on, Pradaxa or Coumadin or whatever, all of the drugs that are out there now, then that might be a concern in the world of expectorants. Now, the opiate suppressants, so the cough medications that have opiates in them, these are the ones that do directly suppress cough centers in the brain. So that makes them very effective in reducing cough. Of course, they also tend to be the most dangerous, as most effective drugs usually are, because cough is a protective mechanism. So it is currently the standard of care that opiate-containing cough suppressants really should be your last choice. It's kind of ironic that the evidence-based guidelines say opiate cough suppressants should be the last thing we use, and yet in day-to-day real life, they get used very commonly. These are things like Phenergan with codeine, Tussianex, stuff like that. Now, given that we're in such an anti-opiate mindset these days, people are getting more and more conservative about using opiate-containing cough suppressants. These can be abused as well. There's a whole YouTube underworld, telling you how you can mix opiate cough suppressants to abuse them. And so you want to be judicious with it. But like I said, for maybe those COPDers that when they get an acute viral URI and their cough actually produces really, problematic episodes of hypoxemia, this might be something to think about, but it should be among the last drugs in your toolbox. Now, in a lateral move, we're not talking about cough suppressants anymore. Now we're talking about probably the last single drug here for pulmonary conditions, and that's theophylline. Theophylline is totally different than anything else we've talked about here, and it's interesting. It's as a drug, it has been around forever. Whenever the topic of theophylline comes up, we always have a conversation about the safety issues and the concerns, and they're all valid. It's true. Theophylline can be potentially a toxic drug, and yet it never quite goes away. It's just a drug that it really does have a role that no other drug in the pulmonary world can fill very well. So even though we recognize that it's got a narrow therapeutic margin, we recognize that there are potential toxicities, we recognize that you have to measure theophylline levels at regular intervals in patients who take this. It is a cytochrome P450 substrate. There's lots of issues to be aware of. You don't want to use this in anybody that you're concerned will not be compliant to come in for their monitoring and stuff. And yet, for the right patient, sometimes this will give you that last piece of symptom control that nothing else can. So, like every other really effective drug, there are potential adverse effects that can be unsafe. There are potential downsides, and you just want to make sure that your patient's a good candidate for it. But if the patient is, this is a drug that can relax bronchial smooth muscle in an entirely different way. This drug, I have found that sometimes with your asthmatics where you just get them on the best regimen and they're doing everything right and they're following instructions really well, and yet they just can't quite get their asthma under control. Like they keep waking up at night. Nighttime is a hard time for asthmatics because your natural glucocorticoids are important in suppressing inflammation. And remember that glucocorticoids are a diurnal hormone. They tend to peak in the morning and through the day, and then their natural levels drop during the night. So at nighttime, our natural levels of glucocorticoid are at their lowest. So our natural ability to suppress inflammation is at its lowest. And so this sometimes is when you'll see asthma breakthrough symptoms. For whatever reason, theophylline is particularly good at suppressing these in patients that otherwise are on the best medication regimens but keep waking up at night. So there's a role for it. It's certainly not a first line or even a second line these days, but do be aware of it. Sometimes it is the drug to use. And again, it is not a rescue drug. It's not like, oh, you're having cough and bronchospasm, pop a theophylline. That's not what this drug is. This is about controller therapy. This is if we recognize that your asthma or COPD or whatever just isn't under good control, we're going to add theophylline to the mix every day. And hopefully in a couple weeks, we will see that those breakthrough symptoms are calming down. So these are the good things that theophylline can do. Increases respiratory muscle strength by promoting bronchial relaxation, decreases macrophage T cells, decreases neutrophils, all these things that can aggravate symptoms, increases clearance of mucus, decreases exudate of plasma. So lots of good things happen in the airway with theophylline. It's just that it's a stimulant. It can be a stimulant in the cardiovascular system. And because it is metabolized by cytochrome P450, there's a potential drug interaction thing there. And the therapeutic range of theophylline is fairly narrow. So you just have to be up on the safety issues. So, in case I hadn't mentioned it, the greatest implications in understanding the differences and the roles of these drugs is to make sure patients understand it. They have to understand how to use drugs. It is really important that they understand that some drugs are controller therapy and some drugs are rescue therapy. Controller therapies keep symptoms from occurring. They keep a condition under control. Rescue therapies rescue symptoms after they have occurred. These are totally different things. The goal is always control. It's a little rhyme, right? So it's easy to remember. The goal of managing anything is control. We'd much rather control than rescue after problems occur. The role of rescue therapies really are to treat those breakthrough symptoms at times when control is suboptimal. And believe me, it's not always easy to get your hands around. I've had nurse practitioner students who had trouble getting their hands around this, so you can totally imagine how hard it is for patients. The most patients know about drugs really is what they see on TV. They watch commercials, and commercials are designed to promote them, to make them ask you to prescribe the stuff, but it's for you to really understand the differences and make sure people understand. Yeah, I mean, same thing. I say this repeatedly because it's just so important. Patients often need repeated instruction. Like for asthma or COPD or any chronic pulmonary thing, at every visit you want to reinforce the discussion of controller versus rescue. I know it sounds like a no-brainer. I know you think, like you tell somebody once and that's it, but it's just amazing how often they need reinforcement. Remember what I said when we first started this discussion. It is well recognized by the National Institutes of Health that there is a huge disparity between all of the good tools that we have for asthma and the poor asthma control in the population. And one of the biggest reasons for that has been identified as that we are not appropriately classifying and we are not appropriately educating. So it's our job as the professionals to make sure that people understand the difference. Another thing to consider are the systemic adverse effects. We talked about antihistamines, first generation particularly. We talked about systemic corticosteroids and systemic anticholinergics, which we don't really have oral anticholinergics for pulmonary conditions, but we give lots of other medications systemically, like tricyclic antidepressants, like bladder antispasmodics. We give those to do other functions in the body, yet they have a profound anticholinergic property that can have systemic effects. So we want to be up to date on those. And then finally, well, not finally, there's 7 more slides, but I think maybe the last important point, all inhaled drugs are not the same. If you don't remember anything else from this entire discussion, please remember all inhaled medications are not the same. This is huge, huge, huge for patient education. If you're going to be in a job where you have any meaningful degree of patients that you're going to have on inhalers, like if you have a component of asthmatics or COPDers or both, one of the best things you can do is get a little collection of samples of inhalers so that you can show people. Because when you're teaching them about how to use their drugs, like for an asthmatic, for instance, we know that with asthma, controller therapy is with inhaled steroids as a start, and sometimes inhaled steroid long-acting beta agonist combinations. That is your daily controller mechanism. Those are not rescue drugs. Albuterol is the rescue drug. And so when I'm trying to teach patients this, I have a little basket of empty inhalers, and I'll pull them out and say, this is your Advair, right? Advair is a controller drug. This is what the Advair looks like. This is the one that you're going to use twice a day, every morning and every night, whether you're having symptoms or not. Like put it in the bathroom, incorporate it into your routine in some day. You get up, you go to the bathroom, wash your hands, use your inhaler, and then brush your teeth. And that has the added advantage of cleaning out the mouth after they use the inhaler, because you know that when you use inhaled steroids, one of the risks is for an oral fungal infection, right? Because you're suppressing bacterial growth in the mouth. So it's a good habit to get into. Every day and every night, the last thing you do before you go to bed is go to the bathroom and brush your teeth. So now, go to the bathroom, brush your hands. Yeah, don't brush your hands, wash your hands. Go to the bathroom, wash your hands, use your inhaler, and then brush your teeth. And then you have gotten your inhaler into your daily routine, and you have cleaned your mouth afterward so that you don't get thrush. And I'll show them the inhaler. This is the one you do that with, and we'll put it over here. Then this is the one that you use when you feel short of breath, or this is the one that you use when you feel like wheezy or like you're coughing. You don't use this every day. If you don't feel like you need it, don't use it. The goal always is that you're only going to have to use this once or twice a week max. And you show them the different things to make sure they understand. And then even at that, when they come back for their follow-up, you're going to have to do it again, because for some reason, some people just really have a hard time getting their hands around it. As I told you before, there used to be a black box warning on some of these asthma medicines because there was an increased risk of asthma death because people were using controller inhalers to try to treat an acute asthma attack, and you cannot. So there's control and there's rescue. Patients must know the difference. The only rescue inhalers are the short-acting beta-adrenergic agonists. These are examples of them. Albuterol is the prototype drug. That's the generic name. Levalbuterol is, its chemical mirror image. Proventil, Ventolin, and ProAir are just all brand names for albuterol or levalbuterol, but short-acting beta agonist, that's the feature that you're looking for. Any drug that is a short-acting beta agonist is rescue only. These are drugs we don't want people using every day. In fact, good management of chronic pulmonary diseases means that patients will need to use these less than 2 times a week. If you have a patient that has to use a rescue inhaler, a short-acting beta agonist, more than twice a week, that patient needs to have their other medications adjusted. Not only are short-acting beta agonists bad because these are epinephrine, these are sympathetic stimulants. These will make you tachycardic and hypertensive and tremulous and agitated and all of that. But also, if patients are having to use these too often, it means that whatever the underlying problem is, it's not under good control. It means, for instance, if they're having asthma, they are having episodes of bronchoconstriction and increased mucus production and hyperemia and all that kind of stuff. We don't want that going on. We want to get their underlying condition under control. So, critically important point. Rescue inhalers should only be used to rescue symptoms. They should only need to be used less than twice a week. If they need to be used more than twice a week, we've got to fix the underlying problem. Now, having said that, if they're in a crisis state and they need to use it, they should totally use it. If they're having an exacerbation of their asthma and they need to use this 4 times a day, they should totally use it. I mean, we want them to use it because this is the rescue drug. But if they're using it that much, that is our clue that we need to investigate why are they having to use it so much and fix it. All of the other inhalers here are disease control of some sort or another. Inhaled corticosteroids, inhaled anticholinergics, inhaled long-acting beta agonists. And there are many products out there now that are combinations of one or combinations of 2 or even combinations of all 3 of these in one brand, in one container. But all of these drugs are your controller therapy. Inhaled corticosteroids are truly the foundation of chronic asthma care. Every asthmatic that needs to be on controller therapy, daily controller therapy, should be on an inhaled corticosteroid. So if your patient is having to use albuterol more than twice a week, make sure they're on an inhaled steroid. If they're not, get them on one. If they're already on one, maybe the dose needs to be increased, or maybe yet another drug has to be added. But every chronic asthmatic should be on an inhaled corticosteroid. That's point. And these are just some examples. There's a ton of them out there. Again, I'll refer you to that list that I put in your weekly unit as an external reading. Inhaled anticholinergics, these currently are used more often in COPD than for asthma. There is a role for them in asthma, but in COPD, they are a first-line drug. And this is because in COPDers, it's believed that there is inappropriate cholinergic stimulation, which leads to some of the chronic cough and bronchospasm. So ipratropium bromide is Atrovent. That's your short-acting anticholinergic. Tiotropium bromide is what is that? Spiriva. That's your prototype long-acting one. And then there's several newer long-acting ones. Euperli is one. I'm sure there are others. You can refer to the list. I just wanted to give you some examples here. We have many combination agents, and you totally want to be on top of like one versus the other because different combo agents have different things in them. And again, people will watch commercials on TV and they see like ladies running around in fields in a flowery dress, all breathing well because of their Brio. And then they come back to you and say, oh, can I take Brio? Because I want to breathe like the lady on TV. But you know that that combination is not what they need. So really be aware of what's in these combination agents. We've said 3 separate drugs for controller therapy are inhaled steroids, inhaled anticholinergics, and inhaled long-acting beta agonists. And there are many formulations of inhalers where it's just one drug per canister, like Flovent is an inhaled steroid. Qvar is an inhaled steroid. There are many formulations of just one anticholinergic, like Spiriva. That's all Spiriva is an anticholinergic, which we call long-acting muscarinic antagonist. And then there are formulations that are just a long-acting beta agonist, like salmeterol, which is marketed as Ceravent, and formoterol, which is marketed as Foradil. But then we have the combos. So what you see here are combinations of a long-acting beta agonist with an inhaled steroid. Notice there's no muscarinic antagonist here. There's no anticholinergic. These combos shown on this slide are just inhaled steroid and long-acting beta agonist. Advair, Symbicort, Dulera, and Brio. These are the ones that are all over TV. And they're just different forms. They're different steroids with different long-acting beta agonists, right? You can see Advair is fluticasone, which is Flovent, and salmeterol, which is Ceravent. So Advair is Flovent and Ceravent. Symbicort is budesonide and formoterol. Budesonide is Pulmicort, formoterol is Foradil. So it's just like Coke and Pepsi, basically. And, you know, for whatever reason, some people may respond better to one than the other, but usually it's about what their insurance will pay for. But takeaway message here is these combos contain only a long-acting beta ag and an inhaled steroid. Now, what you see here are long-acting beta agonist anticholinergic combinations. Notice that there is no inhaled corticosteroid in these drugs. And these are just a few examples. There are more now. These are like spawning. There's like new ones every day. a neuroellipta. This is a LABA, long-acting beta agonist, and a LAMA, long-acting muscarinic antagonist, right? So LABA and LAMA, a neuroellipta or Stiolto, one or the other. And there is, I believe, I'll hold the phone here. I thought I had heard that there was a single inhaler that was a LAMA, a LABA, and an inhaled steroid in the same class. And I don't know that. I just tried to do a brief lookup while I put you on hold, so to speak, and I didn't see it. It may very well be out there. But, oh, here we go. Wait a minute. Well, hold that thought. Well, recently to fix triple. I know I should have known this before I started lecturing, but I'm going to put you on pause for just a second. Yes, there are Trimbo and Trelegy ellipta. Trimbo, T-R-I-M-B-O-W, and Trelegy ellipta, T-R-E-L-E-G-Y ellipta, are two triple therapies in one inhaler. Inhaled steroid, long-acting muscarinic antagonist, long-acting beta agonist. And I mean, I don't come across them because that clearly is something that like a pulmonologist would use. That's pretty heavy duty, but they are available now. And so the only thing really that I would encourage you as far as this discussion goes is just to be aware of what's in those inhalers, because they are different drugs and different people need different things. So they don't, they don't all mix and match as if they were the same thing. And then finally, this is our last slide for this discussion. Roflumilast is marketed as Dolaresp. This is an oral agent, non-inhaler, and this is like kind of like 21st century theophylline. This also relaxes bronchial smooth muscle. It's, what was I going to say? It's safer. It does very much the same thing as theophylline, but it tends to be much safer. It doesn't have that narrow therapeutic margin. It's not a cytochrome P450 substrate. It also tends to be more expensive. So in primary care, I've never written this and had it filled with no problem, although pulmonary writes it all the time. So it's almost as if the insurance companies think if you need to be on this, you need to see a pulmonologist, but it is another option. You can see here that there's some concern about suicidal ideation and weight loss. Weight loss is a big problem in COPDers because they're hypercatabolic, they're chronically hypoxemic. So the last thing we want to do, and this is a later stage drug, like this is after we've been through all the inhaled therapy. So by the time a COPDer goes on this option, their disease is usually pretty advanced. And so weight loss is a problem. They a lot of times tend to be cachectic anyway. And suicidal ideation, I honestly can't tell you I know where that comes from, but I know it is one of the warnings of this drug. So that's all I have to share with you about everything here. Again, just a one lecture week, right? I think there's a lot of that coming up here towards the end of the course. Actually, I think, what do we have left weeks? 8, 9, 10, and 11. And I think only 2 of them have 2 YouTube lectures to do. So hopefully things are lightening up a little bit. Everybody seems to be kind of getting in the groove here. If you have any questions about pulmonary drugs, you know where to find me. Otherwise, I'll see you next week for whatever that topic is.